Analysis of ST changes. For the purpose of explaining, the ST segment changes and T wave changes are described separately, but they are interrelated and will be discussed together wherever relevant. First, we will study the types of depressions of ST segment. ST segment depressions are basically of three types. Number one, strain pattern in right and left ventricular hypertrophy. Number two, digitalis effect. And number three, myocardial ischemia and infarct. This ECG shows left ventricular hypertrophy with deep S waves in V1, V2, tall R waves in V5, V6. Now observe the lead V6 in the inset. Note the ST depression of the strain pattern. In leads V5 and V6, there is mild depression of the ST segment and T wave inversion. This is left ventricular hypertrophy with strain. Now this ECG shows prominent R wave in V1 with mild depression of ST segment and T wave inversion in V1 and V2. This is right ventricular hypertrophy with strain. These are the strain patterns. Now the second type of ST depression is due to the effect of digitalis. This is the typical ST segment depression due to digitalis, described as mirror image of check mark. It slopes downwards gently and then rises steeply. It is best seen in leads with a tall R wave. The T wave amplitude is reduced, and with severe toxicity, T wave becomes flat. In this ECG, note the typical ST depression and also other effects of digitalis, that is prolonged PR interval and bradycardia. Note again in close-up view, prolonged PR interval, typical ST depression and flat T wave. The third type of ST segment depression is due to myocardial ischemia and infarct. At the onset, let us clear our mind from the reciprocal ST segment depressions in acute myocardial infarction. This is inferior wall infarct, where leads 1 and AVL show ST segment depression and 2-3 AVF show ST segment elevation. The anterior and inferior group of leads show opposite effects on ST segments. Note the ST segment elevation in leads 2 and ST segment depression in lead AVL. In contrast, this is an anterior wall infarct where leads 1 and AVL show ST segment elevation and 2-3 AVF show ST segment depression. Now we will see various types of ST segment depressions due to myocardial ischemia. Observe the lower ECG first. During an acute attack of angina pectoris, ST segment is depressed by 1 to 2 millimeters, particularly in leads V5 and V6. But this is a transient change. In the upper ECG taken 2 hours later, the ST segment has returned to normal. This is typical angina pectoris or Heberden's angina. A mild ST segment depression in V5 and V6 with low amplitude or inverted T waves is a typical feature of chronic angina. Mild ST depressions in V5 and V6 with inverted T waves is usually due to chronic myocardial ischemia or angina. So ST segment depression in V5, V6 suggests coronary artery disease or left ventricular hypertrophy with strain. In absence of ventricular hypertrophy, it strongly suggests myocardial ischemia. ST segment depressions in leads V2 to V5 may commonly be due to reciprocal changes of inferior wall infarct or due to subendocardial infarct. Now here we see an ECG of inferior wall infarct. Note the ST depressions in leads V1 to V4. The T waves are upright and it will be associated with ST segment elevations in 2-3 AVF. So this is reciprocal ST segment depression of inferior wall infarct. When there is ST segment depression with inverted T waves, as in this ECG, where the ST segment is depressed and T wave is deeply inverted, this is subendocardial infarct. When only the subendocardial portion of the myocardium is infarcted, not the full thickness but only the subendocardial portion of the myocardium is infarcted, then several chest leads show ST depression with T wave inversion. Normally, when full thickness of endocardium is infarcted, there is ST elevation with tall T waves. But when only subendocardial infarct occurs, there is ST depression with deeply inverted T waves in chest leads and anterior leads. This is subendocardial infarct. At this stage, let us remember the picture of anteroseptal infarct, where the ST segment is elevated and T wave is inverted. Compare here on the left ST depression in subendocardial infarct, and on the right ST elevation in anteroseptal infarct, both with inverted T waves. If the ST segment depression is seen in leads V1 and V2, it is usually not due to ischemia. It may be due to right ventricular hypertrophy with strain or due to true posterior wall infarction. So if the ST segment is depressed in V1 and V2, look for the R wave of right ventricular hypertrophy in V1. If the R wave is prominent and T wave is flat or inverted, then it is right ventricular hypertrophy with strain. And if the T wave is tall and ST segment is depressed, it may be a true posterior wall infarct, which is seen on ECG as reciprocal changes in V1 and V2 with ST segment depression and tall T waves. Note once again ST segment depression and tall T waves in V1 and V2 in posterior wall infarct. To revise, ST depression with T wave inversion in V5 and V6 suggests myocardial ischemia. In V1 and V2, tall R wave, ST segment depression and T wave inversion suggests right ventricular hypertrophy with strain, while ST segment depression with tall T wave suggests true posterior wall infarct. In the middle leads, ST segment depression with flat or upright T wave is usually due to inferior wall infarct with reciprocal changes, while ST segment depression with deeply inverted T wave is due to subendocardial infarct. ST segment elevations. ST segment elevation is the hallmark of acute phase of myocardial infarction. The changing pattern of T waves gives us two different pictures. This is ST segment elevation with tall upright T wave. So the ST segment is concave upwards. This is seen in the hyperacute phase of myocardial infarction for first few hours. This is ST segment elevation with inverted T wave. So the ST segment is convex upwards. This is the picture 1 to 2 days after an acute attack of myocardial infarction. It is important to note whether there is reciprocal ST depression in the opposite leads. That will confirm the diagnosis of infarction. Note the ST elevation in lead 3, which is the inferior wall lead, and reciprocal ST depression in chest lead, which is the anterior lead. While in this ECG, there is ST elevation in the chest lead and reciprocal ST depression in the inferior wall lead. So the second important point to note is the leads showing ST elevation which will localize the infarct. And third point is the nature of T wave, which will tell the age of the infarct. Remember once again that ST elevation with T wave inversion is seen only in established myocardial infarct. The second cause of ST segment elevation is acute pericarditis. This ST elevation is concave upwards with upright T waves. So it mimics hyperacute phase of myocardial infarction, and even clinically the pain is identical. But pericarditis is a diffuse process. So ST segment elevation is seen in all leads, anterior and posterior, and chest and limb leads. Though sometimes all leads may not show ST elevation, causing a confusing picture. But reciprocal ST depression will never be seen in pericarditis. So reciprocal ST depression rules out acute pericarditis. To revise, ST segment elevation is the representation of acute phase of myocardial infarct. Convex upwards ST segment elevation with T wave inversion is seen only in myocardial infarction, while concave upwards ST segment elevation with upright T wave may be seen either in acute infarct or in acute pericarditis. Reciprocal ST depression is again a diagnostic feature of acute myocardial infarction, while in pericarditis all groups of leads show ST segment elevation.